are in charge of. And okay, so it's being recorded, Helen.
Yep.
Somehow.
Yeah,
right.
she said she's logging on.
Awesome. Level 3s and level 4s. As I look at the list of names, I see some new names that aren't familiar to me. If you're new to our group, would you be willing to just speak up and tell us where you're from? So just feel free to take yourself off mute, and we give you a welcome. Just give us your name and your role and what hospital you're at.
You know, I haven't met Scott. Scott was just on the call. Scott Richardson. Oh, he's gone now.
Okay.
Hmm.
All right.
Morning. I'm Scott Wilkinson with Muskegon County Med Control.
Your what? I'm sorry, your name?
I'm Scott Wilkinson with Muskegon County Med Control.
Oh, great. Very good. Welcome, Scott. Anyone else that's new to our 10 o'clock hour?
Dr. Kramer's new to the 10 o'clock hour, but he's not new to our group.
That's true. Welcome, Dr. Kramer. You can listen in, participate.
Good morning. Thank you.
Yes, you're welcome. This morning is focused on PI examples. So as we think about how do we demonstrate, particularly to our reviewers, that we're doing PI and we're doing it effectively, what are some of the very practical examples that people can do to show the reviewers what PI looks like at your facility? I think we're really blessed in our region that we actually have reviewers as part of our group, both nurse and physician reviewers. So we have these experts right in our midst. And so I'm inviting them also to, as they always do, give us feedback, give us their insights, because really who has the opportunity to talk to ACS reviewers except for during our reviews or to state reviewers. So we're at an advantage here. We have several people who have volunteered to share some examples. If I am missing anyone in this list, please speak up because we do want to hear from you. Mo from Helen, Lindsay from Helen DeVos, Jennifer from Blodgett, and myself. So is there anyone else that's prepared to share a PI example today that I might not have on that list? You know, some people are on vacation this week. Okay, and then at the end of our time together, I'm going to ask Helen to do a preview of OPPE, which may or may not be a term familiar with you, but is something that we would like to be sure that everyone is comfortable with and perhaps, you know, give some ideas. So I'll turn that over to Helen at the end of our time together. This time is always for questions and answers and dialogue. This is more of a dialogue than it is just an actual presentation. So we use presentations, short presentations, just as a spinoff for the dialogue that can happen. So Mo, can I ask you to lead off with your example of PI? Mo
Yes.
from Helen.
Yep, I can
Yep.
do that. Do you want me to share my PowerPoint, or Helen, were you?
Yeah, can you
I
see
sent
it? I'm sharing right now, but maybe it didn't go through again.
Not
There you
yet.
go.
Oh, you do see it now?
Oh, nope, I don't see it. Sorry. I saw my own.
Whatever you did last time, Helen, do it again.
I'm trying. It's like got its own mind. All right, we'll try it one more time. I have to find Holland.
So while Helen's figuring out that, I can kind of talk a little bit about, so we're a level 3 facility in Holland, Michigan, and we recently went through our re-verification in June. And so one of the PI projects that we had worked on during that period for our re-verification was CT read times. We had noticed an increased trend in read times for our trauma activations. We have always had a goal of having those read in under 30 minutes. And in 2020, we noticed there was becoming a longer and longer read time. And so in order to really identify what the problem was, or if we had a problem, we just felt like we had a problem, we started tracking that. So we used the Plan, Do, Study, Act model to really hone in on what the problem was. So you go to the next slide, Helen. So in 2020, we identified, or we felt like we identified a trend in increased read time. So what we started doing is tracking those CT read times for about 6 months, just to get some insight into average read times, how often they were read in over 30 minutes, and then investigate reasons for the delays. Once we looked into that, we brought that to our radiology leadership team and ARS leadership, which is who reads our scans. And we reviewed the cases with them, and we looked for potential reasons why they had gone over 30 minutes. So during that time, we identified a few issues that we could look at. So for example, a trauma scan should have a tech alert on it that kind of flags it for the ARS read group. So those weren't getting put in consistently. So we set a goal of 80% of the time meeting, the reads in less than 30 minutes, and then we started monitoring that. We provided education to the staff, specifically to the CT techs, because those were the staff that has to put in that tech alert. And so then we provided the education, and then in 2021 we started monitoring all of our activation read times. So any case that was over 30 minutes, we sent to radiology leadership and ARS for review to get a more detailed timeline of what possibly happened. And then if we found something in the moment, we would do that education right away with CT staff. So, or ARS if it was on the other end. So you can go to the next slide. This is just kind of one example of how we tracked it. So it wasn't per patient, it was per scan. So this patient had multiple scans, and out of all of those scans, 3 of them were over 30 minutes. So we looked at the reasons why. So the chest, abdomen, pelvis, that one is the one we found that most often went over the 30 minutes. And it would seem like the head and the C-spine would get the tech alert, and then the chest, abdomen, pelvis would be missing the tech alert, which is what flags it on the ARS side for a stat read. So we'd actually had identified a trend in that it was night shift in a certain tech that was not doing it. So we did some education, and we saw some significant improvements that year. So you can go to the next slide. So this was our goal. So we brought this to our trauma committee for 2021, and then continued to track it. So the next slide shows our progress. So first couple of months we did really great, and then in March it kind of had like this up and down, and those were the months where we determined that actually the tech alert was not getting put in, and there was a certain group of techs that weren't aware that it needed to be put in. So we re-educated and continued tracking, and now have been meeting that goal more than 80% of the time for most of 2021. And then this year we're starting to see, but we never stopped tracking it. So we did finish that. We closed the loop. We met our goal, but we never stopped tracking it. And we've actually determined now we've had another drop. So we're going back to the drawing board again and looking at it to see what is happening this time. So we're currently re-looking at this goal right now, but that's how we started with this goal. And it was one of our biggest projects for 2021. So this is what we used for our PRQ example. Do you want to have any questions on how we did the reviews, or how we showed our work?
What was the thing that you think led most to your success, Mo?
Just in the moment education. So if we were identifying, we found that the closer to the actual time that it happened, like if we got 3 months out or further out, then it was harder to follow back up on it. So doing in the moment education, at that time in 2021, Lauren and I were able to keep up a lot closer on our chart reviews, and in the moment reading these, trauma activation CT times, and like monitoring their length and getting back to the staff right away. And then we actually brought it to our data trans council too. So it was a project not just for our trauma group, but also for our hospital. So we had the involvement of, radiology and leadership and administration. So it was highly supported by those groups. And I think that really helped with the success too, because there was a lot of focus on it.
Mo, you said that you continuously tracked it. At what point do you think you might be able to just go to, spot checks or occasional tracking?
I just don't think we're quite there yet because we just finished it out in 2021. And this year we've already identified we've kind of backslide. So I think it's going to be at least another year of tracking before we can say that. I'd like a really good full year of good data of meeting our goal before we can just spot check it. So.
Great. Well, thank you, Mo. Thanks for sharing that.
Yeah, thank you.
I appreciate your input.
Well, this is Sherry. I just wanted to make a comment. This is a great example of how you're integrating with your hospital PI and your trauma PI. And it then lends itself to more success for your trauma too, because you've got more people behind it. So that's a great example.
Yeah, and I think, just to add on to what Sherry said is we have a specific quality person, a PI coordinator for the hospital that's assigned to our trauma projects, and he's really great at helping us set up, Excel sheets and tracking and a very good insight into tracking quality issues. And so that's really helpful too, because not only does he help us with trauma, but he helps us with massive transfusion, and having that really a key person in the hospital PI program to be a part of that is really helpful.
Wayne, do you think from a reviewer's perspective, this is what you would be looking for when you're looking at the PI examples? Yeah.
Yeah, this is perfect.
Great. Well, thank you. Lindsay, can you share an example from children?
Yeah, I sure will. All right, so let me know. I'm going to share my screen. Can you see it okay?
We are, yeah.
Awesome. So the example I'm going to share today is actually something we did recently in regards to open fractures and our antibiotic time. I thought this would possibly apply to more than just my center as well. So just real quickly, just like here's our data from, this was actually 2021. This is something we share monthly at our trauma review with our committee. We track the antibiotic time when patients arrive. So the time when they come here directly from the scene or when they walk in, and when we do get it within 60 minutes or greater than 60 minutes. And then we actually do track the outside hospitals too, just to be sure that they had received some. So we were noticing that we are starting to have increased misses with these within 60 minutes. So just trying to look at that process and see where we were missing it. So we kind of looked at it from like multiple angles. When we do have a miss, we try to look back at the charting or speak to the nurses or the staff. When was the open fracture identified? So was it an obvious one? Was it obvious when they came in, or was it more subtle? And who was it that identified it? Was it the provider? Was it a nurse? Was that communicated? And then we look at the timing of the antibiotics. We look at the time that the order was placed, the time that the order was verified, when the nurse received the medication or when the pharmacist dropped it off, and then actually when it was administered, and looked for any gaps in that. Was it a staffing issue one night in the ED or something? And then any of these we do look at from just like a level 1 perspective. We review it by our PI team and just verify this with our TMD, Dr. DeCou. And then from there, when it's identified as a positive miss, we do send this feedback back to our ED team and our orthopedic team for review. That's kind of our review process, for any kind of miss. So when we were looking at these misses, it was kind of all over the place. So we kind of worked together as a team and looked at our literature just to see what other kind of PI has been done around this. We had discussions with our trauma, ortho, ED, and pharmacy teams, if were there any barriers on their part. We ended up providing some education just for some standard workaround for the nursing aspect of it. And then just continuing to monitor the process and change, and then providing the results to the teams for that loop closure. So I'll show you what we ended up doing. This is a piece of standard work that we actually put together for our nursing staff, and we have this at triage. So I think just by showing them examples of what an open fracture looks like, making sure that they're taking down the splint or looking at the wound, as soon as the patient arrives, really helped. So we placed this on our MDI board, and at each shift huddle, this was reviewed for 1 week straight. Good feedback automatically. I think that next week we had an open fracture who got it, within 40 some minutes. So it seemed to work well. And then just kind of our ongoing review. Here's our data from 2022. And we didn't have any misses actually until June. And that case was actually one that was a pretty complicated road rash situation. And the open fracture wasn't actually identified until the patient was in the operating room with the orthopedic team. So kind of an understandable miss, I guess, in that case, kind of a hard one. But this is information that we share back with our teams every month, again, at our trauma review, and we will continue to kind of look at this. Any questions on this one?
Hey, Lindsay, this is Angie at Lakeshore. Can you hear me?
Yes.
Hey, just wondering if you would be able to share that slide
Yeah,
show,
sure
just
can.
because I could use it almost like a template and be able to use it for our review.
Yep, I sure will.
Thank you.
Yeah.
So this is Megan. I started using the flow sheet that you came up with for the open fractures when I do the trauma orientation for new RNs. And I've noticed a shortening of doctor notification time. So these nurses I actually give them that flow sheet to take with them and look at it. So it's been really, really helpful for me.
Yeah, I believe we keep it at our triage area too, just for reference.
Lance, I see you have your hand up.
Just as long as we can kick off Todd for just a second when I ask this question. It's just, it was interesting that you used that, Lindsay. There has been a movement from the EMS side to push out the antibiotics pre-hospitally over on the east side of the state. I think Washington, Livingston now has the approved protocol. Helen, I don't know if there's any other regions that have kind of jumped on board with that or not, but just kind of wondering from your perspective, is there a benefit for considering that for some of our outlying EMS agencies in our region?
I personally haven't looked into it here. I mean, I think our transport times to our facility are quite short. So I'm not sure what the difference between the east side of the state and here would be for that. I think when we looked at the literature, kind of that 60-minute was kind of a good time frame. So I guess we could start looking at the time, from injury to time of antibiotic and see if that would make any difference.
Yeah, again, thinking about where Angie is up in Oceana, Mason County, some of those outlying areas, if there's a potential.
And that is feedback we give to outside hospitals too. If there was an open fracture and they didn't get an antibiotic, that would be feedback we would give to them, just for their own education and growth.
Lance, this is clearly not unique to the east side of the state. Can you tell us a little bit about why they're doing this? And is it all intravenous or is it some oral and some intramuscular?
I'd have to go back and look specifically at the protocol. I believe it was all IV administered, but let me just quickly review that. And Helen, you may know more of that from just the regional trauma coordinators conversation. I know it was kind of pushed from, but Helen's shaking her head at me, so maybe I'm setting her up for failure, and I apologize for that.
Well, Dr. Kramer has his hand up, so maybe he has some insight into it.
Yeah, there is a lot of interest nationally in EMS potentially providing primarily IV antibiotics, unless you're in a wilderness setting. Excuse me, and then they go to PO. I think it's generally with the goal of ensuring that the antibiotics are on board as quickly after the injury is identified. Candidly, there are a number of metropolitan areas that are doing it. There are some rural areas, but it's more difficult actually to implement in the rural areas just because of staffing and available supplies and things like that. So there is a lot of interest nationally. I'm not sure that folks have demonstrated that it makes a significant clinical difference. It does make a time difference, The question is, what's the significant clinical difference? Todd?
I'll just Lance knows that this is one of my pet peeve issues here. Totally agree with John. This makes for great trauma metrics that we get excited about. I think makes a minimal clinical difference to add antibiotics to the pre-hospital environment with the associated costs, number of times it's going to be used. It's not something that I think is a region that is high priority with all of the other trauma issues that we could be working on, but that's my 2 cents.
All right. Well, thanks for the discussion. This may come up in the future, but I do think that was a great example, Lindsay, of something that affects all of us. Every hospital in this whole system is going to have open fractures and have a goal of getting antibiotics within that 60 minutes. So Lance will count on you to keep this alive as a potential discussion if there's a need for it, okay? Jennifer from Spectrum Blodgett, are you ready to share what your PI project was?
Yvonne, I don't see her on the call at all.
I was just looking at the list. I don't either.
Yeah, I don't see any of the PI nurses from the adult side.
I
Gabby,
wonder-
do you know?
I just put a request. This is Kelly. I just put a
Okay.
request into Jen to join the meeting.
Okay,
Okay.
cool.
I
Thanks,
see
Kelly.
she just sent
No,
me
I
her
don't know.
presentation.
Okay. Maybe she's just having trouble connecting. Why don't I go ahead and then we'll come back if she can join. We'll invite her. So Helen, are you sharing mine or do you want me to?
Either way, which one is yours?
The
I'm hav-
one,
Pardon me?
the one, CT,
Okay,
head injury, navy blue beginning slide.
it's trying. Okay, can you see it?
Yeah, I do. Right.
Okay, awesome.
So I'm doing a little bit of a different angle. This is not one that we have completed. This is actually one that we're just beginning to dig into. And so I thought I would just take it from like, how do you start? If you identify that you've got a PI issue, how do you know it's a PI issue? How do you decide it's one you want to work on? And what are some of those initial steps that you would do? So next slide, Helen. So our PI issue in this case comes from, Helen, will you forward that for me, please?
I did. You're not
There you
seeing
go.
it.
Oh, thank you. Yeah,
Okay.
thank you. So this is time to CT for head injury on a blood thinner. Our goal that we want to work toward is 60 minutes. And more specifically, I would say that our goal is to have the time to the CT for head injury on blood thinner within 60 minutes, 90% of the time. So it's obviously, 100% would be ideal, but we want to be realistic. So we're looking for it to be 90% of the time and we get it in 60 minutes. And we're moving this goal from being 120 minutes. So when our goal is 120 minutes, we're almost 100%. So now we're saying, can we do better? Our current state, looking at 60 minutes, is 78% of the time we get the CT within 60 minutes of arrival, but we want that to be at least 90% of the time. So how do we begin looking at this issue and saying, where do we start? So the first thing we want to know is who's closest to this process, who's going to know the most about it, who's going to be able to impact it the most. So in this case, it's going to be triage nurses, ER docs, radiology staff, and some of the other staff. And then, of course, the radiologist who reads it. How is it measured? Where does the process begin and end? So that sounds like an obvious question, but it doesn't become obvious at all because you really have to have very defined points at each end of your process that you're measuring. So for us, we're using the beginning time as ED arrival. So the minute they get registered in that computer, that is their arrival time. And then what we use as the process, in terms of a CT start time, is the time stamped on the CT image. So different people can use different times for that, but that's what we've decided to use as our data point is we look at that initial CT image and whatever time is on that image, that's what we use as as our timestamp. So that's just an important thing, is to be very clear about what is the time process that you're measuring. And then we began to take a look at that process to say, well, what are the time segments that are made up in that? So it is arrival to triage complete, triage complete to the patient being roomed, room to the ED doc order, and the order to the ready for CT, and the ready for CT to CT start. So we could look at any one of those processes to look at the next point, which says, where in this whole process is it not working the way it needs to in order to reach the goal of 60 minutes? So we could look at each segment of that and say, the best we can do in this segment is, 10 minutes. The best we could do in this segment is, 15 minutes. And we add all those up and say, is 60 minutes even a realistic goal? If it is, then we can look to say, well, which of these could we do better? And so in order to do that, we have to measure kind of each of those segments. So finding a way for us within Epic that we can take a look at and even run reports on each of those time segments to say, where is this time being used up the most of the time? And then we also can ask why and how questions, which will help us get at what needs to change. So if I go back to the process, arrival to triage complete, we can ask some why questions and some how questions and some what questions in there that, we start with saying, do all the nurses who do triage know that this is a high priority patient? How soon do they know in their questioning process that somebody with a potential head injury is on a blood thinner? How long does it take us to recognize that? Is this patient always given a high priority in the triage process? So that they get a priority for the beds in the back. Is there a way to alert the ED physicians sooner that perhaps that order can be put in? So right now, we mostly have the patients have those orders put in when they're in the back, but if we really want to get it in a shorter time frame, could that be done differently? Do we have a long period of time where we say the patient is ready to go to CT, but the CT hasn't started yet? So where is that time frame? So really, it's just a matter of asking a lot of questions. And again, the people who know the most about the answers to these are the people, working with us every single day. So a lot of conversations go on about, help me understand how this works, and a lot of data analysis. Once we identify all of those things, then we're ready to say, what could we do differently? And then that's when we will develop an action plan and then begin remeasuring the results to see if there's a change, very much using the PDSA cycle to do that. So this is one that we are really just in the very beginning process, looking at the time measurements of the segments of the process, and then beginning the conversations with people saying, are we doing this? Could we change steps in the process? Could we do this differently? What's not working and why? So any questions, comments, suggestions? Have any of you dealt with this and found something that works really well?
Yvonne, I like how that you started your whole project by identifying the people involved in the process rather than just thinking up the solutions and telling them how it should be. getting them involved.
Mm-hmm. I think I've learned by doing, Helen, that this is a better way to go.
I agree, Helen. That's a really good point, because I think the most speed bumps that we've seen with PI projects or process changes that we've tried to implement is just making either a knee-jerk assumption about the workflow in a different department or, slowly getting the correct people involved. So that's a really good point.
I think the best thing in PI is usually identifying the stakeholder. Any project you're going to do to solve your PI issue is go beyond the border of trauma, and you need to identify the stakeholder. And once you identify the stakeholder, having them and presenting the problem for them, you're going to get a much better solution and much better outcome than if you propose already the solution and go and tell people what to do.
I think the other thing that is really important, and what I have found is that once we start measuring this, and a lot of times if you go to the people that are involved in the process and show them how it's actually working, often they're surprised. Like if you just talk to them, they may think it's working fine. But when they start looking at data, especially data that's broken down into segments of care, then it begins to help them see, this is why we're concerned about this. This is why this doesn't seem to be working.
Yvonne, I have one question for you. What you did is very labor intensive because you needed to provide the data and the fact to people. Having said that, how were you able to measure, I want to use the word accurately, this in a medical record? Most of the data entered is not usually timely. How were you able to measure that accurately in the medical record?
Because I mean, we had to really think about that, but all of these points that we're measuring are distinct data fields in Epic that are so arrival, that's when the patient gets entered, triage to room. I mean, once they get in the room, that's time stamped in Epic. Room to ED doc order, we can measure that segment. I mean, the minute the doc puts an order in, it's timed. Order to ready for CT. So we have in our Epic a system where we have to say they're ready for CT. It's in Epic. And then, so that's time stamped. And then the CT start time is an image on the film.
I can tell you, and I'm sure Wayne has the same concern when we go and review hospital. I've personally given up on the ED sheets because the time doesn't make any sense. It rely on when the nurse have entered the time, and it doesn't make any sense. So I personally give it up. I don't know what Wade does with it.
Yeah, I'm the same way. I think if Epic could track by chip locator, like they do for the Easy Pass on the highway. So if all this was entered in human free.
Sure.
See, Wayne, you have more gumption to address political issue than I do. Yeah. Nobody mentioned chipping people.
No, but whenever this is what Gabby's bringing up is exactly right. The only things that are kind of when the CT starts moving, if it's a G or Siemens or one of the Siemens or one of the other ones, it's time stamped by the computer. The rest of it, if it's entered in by people, can always be somewhat difficult. I guess when the physician enters the order, that's time stamped by Epic, but yeah. So I appreciate, I'm with Gabby. This takes a huge amount of effort and is always difficult to know which part of the process is breaking down.
Good for us to consider.
Guys, I might have to come off. My computer is forcing me to restart. I'll join in a few minutes.
Okay.
Bye.
Well, thanks for that feedback. Kelly tells me that Jennifer has joined our meeting. So Jennifer, welcome. We would love to hear about your PI project from another level 3, Blodgett Hospital.
Thank you. I apologize. I was MIA at first. I never got the invitation until literally at 9:59. I thought it started at 11. So I deeply apologize. I'm going to talk about, can you guys all see my screen okay?
Yes.
Okay. So I am going to talk about how us at a level 3 at Blodgett implemented the brain injury guidelines. This actually turned into a giant project. It initially started back in 2017, and it is continuing to grow. So it's been kind of nice. I put this in here just because I think we all need a reminder of what the quality improvement actually is. It's just basically leading to a process that we can continually measure the outcomes. So I think that's like a key point of this is, I think if you just use subjective, hey, it's working, it looks great, I think it can be very much skewed. So you actually have to have measurable outcomes. So it initiated based on our very first Michigan State designation attempt, which Blodgett did not pass initially. And this was one of the criteria deficiencies that they obtained. So these are the new ones. I know back in 2017, they were worded a little bit different, but basically the long story short is that we didn't meet the state requirements. A trauma facility must have a plan approved by the trauma medical director that determines which types of neurosurgical injuries, AKA skull fractures, TBIs, you name it, can remain and what must be transferred. So here is the newest level 3. And of course, I know that we all have different ones. So make sure that you're just aware that these are level 3s, not 1s, 2s, or 4s. And they may be worded a little bit different, but it basically says we must have a plan approved. There must be an agreement in place with that appropriate level 1 and 2. And in all cases that are admitted or transferred, the care must be timely. And I think that's a big thing too, that sometimes we forget and gets overlooked. So we, back when in 2017, 2018, when we initially did not pass and we had to make a bunch of improvements, we found a project that was led by Dr. Joseph and then all these other authors that had started in 2013. That was their implementation of their initial brain injury tool. So this is back one of the publications that they had put out there in their initial brain injury guideline tool. So we took that and turned it into a giant group project, right? Who loves group projects? None of us. So especially for school or anything else that you have to depend on other people. But it was huge. It was the medical directors from our level 1, the regional hospitalists, surgeons, consulting physicians at the level 3, all of the other providers in between, from neurosurgery to neuropsych to especially radiology was a big part of this, and then a ton of leadership, including the transfer center and nursing, right? So how did we start? We looked at that data so we can objectively measure it. We took back an 18-month retrospective study. We pulled it from our trauma base, AKA Kelly, who's our main huge guru and helper in all of this. And what we did is we pulled a bunch of different specific data points. Who had patients that had come in with any sort of AIS injury code that had located to the head? What risks did we capture for them? We do capture the camps, the Coumadin, the aspirin, the Plavix, everything else. And we also capture the disposition, all in basically a report that we can pull specific data points and run. What was the length of time in the ED before we got to our disposition point, whether it be transferred or admitted? We pulled all of these data points to make sure that we even had the patients to implement a study, because what's the point of implementing a study or a project if we only have 3 patients that meet criteria, right? So this is just a couple of things, because I know some of us use different data collection base platforms. Obviously, a lot of us are familiar with the trauma base. So these are the head injuries. And then what I did with the help of Kelly created obviously the critique, and then I created a template that was used, but we started capturing and putting in a review for every single patient that met this criteria. So we could actually put in a review that required further documentation for anybody who met big 1, 2, or 3 guidelines. And then I created a template to look at all of those points to see if we were even going to follow our own rules. So basically we took the original, I'm going to skip ahead because it makes more sense, the original tool, and made it our own. And this is the big thing too, is you have to modify it to make it work for your own facility. So our trauma medical director reached out to Dr. Joseph and said, you said aspirin. What does this include? Baby aspirin, adult aspirin? And he said, yes. So we worked with our associate trauma medical director at our sister hospital, Butterworth, Dr. Chapman, and he kind of did a deeper dive into the potential effects of baby aspirin, because no one had really looked at the difference. And he says, this does have potential serious injuries, so we're going to include it. We added that epidural hemorrhage, just because if anybody meets the criteria and has an epidural hemorrhage, we really don't feel that it's safe to keep them at a level 3. And then the other big thing too is everybody was using the subjective terms: small, moderate, large. localized, scattered, and what defines that? Everybody had a different definition. So we worked with radiology to create a template that was used. So any patients that was getting a CT imaging of the head for potential brain injury, we started using a template to kind of break down and make sure that we're using the same terms as what they are. So instead of using terms as a small, mild, moderate, they actually contain measurements. And that's a big thing too, is so I don't interpret something that's tiny and Dr. Chassie interprets it as a small or moderate. So we're not all interpreting it as something different. The reports will contain those essential components needed to actually itemize into that brain injury guideline tool, so we can see what criteria or tier that fits into. In review, I found a lot of these templates are not being used. So we're working with Dr. Konwinski, who is back to that, you know, those key stakeholders, the group project, to make sure that they're pushing it out on their end. They've got so many different radiology, and it's not like they work in one big room where they can say, hey, announcement, everybody, make sure you use this template. They're all in different sites. They're all in different areas and working at different facilities. So it's really hard to push out and make sure that this is standardized. So that's the other thing too. What other parts to this is making sure that the nursing utilizes this. You know, who uses this tool? Is it the emergency department? Well, the emergency department contracts out with a ton of different physicians, whether it's from ECS or their own hospital, and they always get this. The nursing's always changing, whether it's getting admitted to 2 South or 4 South or 5 East or 6 North or whatever it is. And so we had to make sure that there's a ton of education, making sure that they know that what the benefits are and how we're collaborating nursing into it. So we basically explained it as that this is a streamlined tool used to objectively triage these patients that are coming through the emergency department, using a risk stratification, putting them into that big 1, 2, or 3, making sure that we have a plan for each of these patients. This greatly reduces the unnecessary repeat imaging, which obviously we know is costly, more, you know, exposure to radiation and everything else. The appropriate use of neurosurgical expertise. We've really cut down on what patients don't need a neurosurgical consult, which they have absolutely loved. We were asked, doesn't neurosurgery get irritated because they don't get to, you know, have as many patients? No, they're thanking us for it. Reducing costs and length of stay. We were transferring a ton of patients from lots of different areas, whether it's Big Rapids or Newaygo or Fremont to Butterworth, only for them to get discharged right from the Butterworth back home after they figured out that, you know, they really didn't need to be admitted at this hospital, but there was no plan established. And then in turn, obviously keeping these patients closer to home so they're not wasting all of those resources. The research team at Spectrum Health, that included a ton of different people, from the trauma surgeons to the research actual employees to the registrar coordinator, the registrars, the trauma services people such as like Amy, myself, are just everybody pulled together, and they actually published this article. So it's called Step Up to the Brain Injury Guidelines League, and it's based off of everything that we did at Blodgett. So that's super cool. That was published last year in 2021. And then basically we have to look at who's currently using this. This is the first person to put it into action was Blodgett. And then I took it on as a scholarly project and implemented it at Zealand. So huge kudos to Zealand peeps. And then Butterworth kind of did it at the same exact time. And then emergency care specialists kind of started taking it on as well. And they thought maybe they were going to push it out on their end, but they really have to use the contracted hospitals to accept it. And then obviously their physicians would know about it. Some of the bumps that I kind of ran into, and I'm going to go back to the stakeholder slide, was so at certain level 3s, they don't have the means to admit these patients. And that was one of the big roadblocks that we ran into. So we actually worked with the hospitalists, and they've agreed to admit the patients on their floor. So it's really, you have to work with your own admission plan. At Butterworth, trauma services admit them. At Zealand, the hospitalists admit them. It's basically working for and modifying it for your own hospital. Working with who your radiology is, because if they're continuing to use the terms that we can't itemize it into the specific categories, it's not going to work, because you're not going to know whether it falls into big 1 or big 2 based on how they're documenting it. So you can see here where they fall into different tiers. And then another thing that was really worked on is the follow-up recommendations. Dr. Deshpande in the TBI clinic have agreed to have all of these patients, or any patients that need to, refer to the TBI clinic. And it's actually just an order that they can put into the computer for TBI. They just search it and it pops right up. Because a lot of these people fall through the cracks. You know, they get home and they have got residual effects that affect them for months to years, and they don't even know why. But they were discharged with a mild TBI. So the picture just didn't fit. And so to making sure that they've got those follow-up recommendations was really crucial. Another part too is hospitals really don't have an observation unit. Obviously, we're maxed to the brim. You know, we don't have beds to hold these patients in the ER if they're only observation for, you know, less than 6 hours or 24 hours or what have you. So where do these patients go? And so it's working with your own leadership in your own hospital to figure out the plan for these patients. And then making sure that the nursing knows what neurosurgical changes are that would indicate reaching out to that physician to order repeat head CT if there are changes. So it's a lot of education on their point too, because they're taking care of a whole new group of patients. So any questions? I got a message.
How are you measuring it at this point, Jennifer?
So we're still using trauma base. And so what happens is anybody that has a codable head injury, the registrar is putting it in as a big review. And then the trauma program coordinator, me at Zealand and Megan at, or I'm sorry, me at Blodgett and Megan at Zealand are going through and seeing how they stratify, whether it's 1, 2, or 3. Some registrars, if it's obvious that it's a 3 and they were transferred, or the documentation states that it was 3, they may throw it in as like a big 3 rather than just a vague big. But we're continuing to pull that data, put it in as a review, and then we're running reports to see if there was any fallouts. Some fallouts that I've noticed is patients that were admitted to Blodgett with big 3s were admitted. And so you're like, oh, that's weird. The disposition is, we kept them, so why? But a big part of it is making sure that if the family has discussed goals of care in the emergency department and they don't want further intervention, to not waste that transfer. Don't transfer that patient down to Butterworth only to get comfort care ordered within the next, 4 to 6 hours. And so that's a big thing that we've implemented, made education awareness and stuff like that. And then I pull a report every single TPC that I have, which I do mine every other month at Blodgett, and I pull a review, scrub it so it takes away patients' data information, and then just review it for compliance, which we've been really good with.
Great. Thank you. Very helpful. Does anyone else have any comments or questions for Jennifer? One of the nice things, if you're newer to our group, one of the nice things about this group is we are willing to share anything. So if you see something that someone is using and you want a copy of it, it will be available. Courtney will make things available to us, but also this entire session will be recorded. You can share this with, someone else on your staff if you would like them to hear the presentations today. And again, we're all available. Just email us to our contact information and ask us to share something that was shared today, and we will always be glad to share that with you.
And I have this in Word, so it's easily made to say, whatever, Jen's Bar and Grill, big injury guidelines, or whatever you want to put as your is your place. And so you can make it your own. It's not something you have to recreate the whole entire wheel to make it your own. So I have everything from education to the PowerPoints to the templates to the tool itself. So you can push it out all in words. And I would love to share it with anybody that wants to implement it.
Awesome. Helen, you have your hand up.
Yeah, Yvonne, we only have 10 minutes left, and Michelle has from Muskegon also has a presentation. I'm wondering if we could move that to the next month.
To next month?
Well, October's session.
I'm done if I can jump off.
Michelle, how long will yours take?
I think I'm going to have to sign off, though.
Okay.
We'll need a little bit of a break between this and the next session.
Okay.
Mine is pretty quick, but I think it may be relatively self-explanatory too. And it's totally fine if we don't get to it. It's just not a problem. I think these were really great examples.
All right. All right. Well, and then Helen, did you want to say anything about OPPE? Or you know you have to get off?
Yeah, I just want to let the group know that Dr. Vanderkolk and I discussed this yesterday. There have been some questions about how to demonstrate, how the OPP is used to, evaluate providers and specialties. And I know Amy's been working on that a little bit with some of her centers. So in talking this through, Dr. Vanderkolk recommended that we sort of pursue that through this group, the education session. So at the next session, Yvonne has agreed that we'll provide some more education on that, what that might look like, what kinds of things you might be measuring. Wayne, did you want to say anything more about that?
I know Amy and I serve, and Gabby as well, on stack with Brad, who his name's going on in my head, who has one. Yeah, Eaton Rapids. So if we find a tool in the meantime, I think having a guest speaker about it, Brad, who's at a level 4 at Eaton Rapids, that might help. But yeah, I think we can get something that's a template that everybody can adjust it to their facility.
And even just to understand, what it is that a reviewer might be looking for. It's not necessarily that they're going to look at every single provider's OPP. They just want to understand that you are looking and how are you looking at this. It might be different for every level 4 or level 3. That's all I had, Yvonne.
All right, thank you. And Michelle, thank you for your graciousness, and we'll include your PowerPoint, and if people have questions about it, they can get back to you. We'll take a bit of a break. Your log on for the next session at 11, which is the RTAC meeting, is a different login, so be sure to check out invite for that.